Okay, so it looks like we are live and good to go. Hello, everyone, and good afternoon to all joining us on this live webinar. My name is Fabrice June, and I am the project manager for the local office on minority health at Public Health Dayton in Montgomery County. Welcome to this lunch and learn opportunity titled Injustice in Healthcare, Past, Present, and Future. Over the next hour, we hope to engage in an educational presentation in commemoration of Dr. Martin Luther King Jr. Day that is happening, that's upcoming this Monday, January 18th. Before we jump in, I definitely want to provide some background on, what the local office on minority health is. So let me jump over. So Local Office on Minority Health is a grant program funded by the Ohio Commission on Minority Health based in Columbus. It is dedicated to eliminating health disparities in minority communities through monitoring and reporting the health status of minority populations, informing, educating, and empowering people, mobilizing community partnerships and actions, and developing policies and plans to support health efforts. This local office is based in the city of Dayton and services Montgomery County, but there are also 5 other local offices in Akron, Cleveland, Columbus, Toledo, and Youngstown, just scattered around Ohio. So if you didn't know about us, hopefully now you know. And if you are a local resident, feel free to reach out and connect to us if possible. And if you're joining us from another city, these are some of the other local offices that you may be able to connect with if you are interested in the type of work that we do. So it is through this grant program that this virtual engagement opportunity is being hosted as well. I also want to introduce our esteemed presenter, Dr. Kierra S. Barnett. She will be taking us on a historical journey and also will be discussing some issues that we are combating today. Dr. Barnett is a postdoctoral researcher at the Kirwan Institute of Ohio State University, and she joined the Kirwan Institute in 2013. Her work focuses on the impact of social determinants of health and racial and ethnic health disparities. She has collaborated with state, county, and city public health departments, as well as non-for-profit organizations to address health disparities in communities across the country. And we are extremely honored to have her here today to give this presentation. And before I hand the mic over, I just want to touch on what our focus will be today. And we'll be kind of centered around one of Dr. Martin Luther King Jr.'s famous quotes: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." So we will be looking at the relevance of that statement historically, in the present day, and looking ahead into the future. So that's all for me. I'll just pass the mic over to our real star, Dr. Barnett, and she will take it from there.
Awesome. Thank you, Fabrice. And thank you to the local Office on Minority Health for inviting me to be a part of this conversation today. Let me just make sure I share my screen. So yeah, as Fabrice mentioned, we're going to really have this dialogue and conversation about this injustice in health from a past, present, and future context. All right. So one, just want to start off giving some background information about the Kirwan Institute for those of you who might not be familiar. So the Kirwan Institute is a research institute at The Ohio State University, and we were founded in about 2003, I believe. So we're a small but mighty institute, and we focus on race and ethnicity. And our research and our work kind of falls within these kind of 2 broad buckets. So this first is this race and cognition, where we're looking at the role of individual thoughts and actions that maintain discrimination. And then where my work typically falls is within this structural racialization, which is looking at the influences of our country's racial history on policies, practices, and values that have perpetuated this racial inequity. And in the work that I do, this inequity that then bleeds out and impacts our health outcomes of our minority communities. And so that's where our buckets fall into. And so then I have our Twitter handle and our Facebook here that you can learn more about Kirwan and the work that we're doing. So just an overview of this conversation I'm going to have today. My goal is to leave time for us to really have a discussion. I know this is virtual, and that can be a little different than if it's in person, but one of the things I love about doing these engagements is being able to talk to people and get their feedback and hear their stories, because I think there's expertise that we all have that we can bring to the table and learn from one another. But we're going to have this brief conversation about health inequities, giving some few examples. I want to have a conversation, which is where the bulk of this presentation will focus on, is the social determinants of health, and focusing on what are they, where do we see disparities, and how does this relate to historical policies, and then have a conversation about health equity and how do we get there.
Before you jump in, Dr. Barnett, I'm sorry to interrupt. It doesn't look like you're presenting It looks like we can see all your slides. So I don't know if you need to make an adjustment on your end, but just wanted to let you know.
Okay, let's see if that helps.
Perfect, there you go, right there.
Great, okay, thank you. So yeah, so we are first going to talk about these health inequities. So not shocking for many of us who work in public health or health in general, but we know that across the life course, minorities, but especially the Black population, carry a large burden of morbidity and mortality in this country. We see this, we look at, so this graphic, and I won't touch on all points, but it's really looking at Montgomery County and the racial disparity that you see within the county. This is not, this is not unique to Montgomery County. We see this across the US in terms of these different health disparities. So for example, we see that Black babies in Montgomery County are dying at 4 times the rate of white infants. We see that the life expectancy is about a 5-year gap between Black adults and white adults within the county. Increased rates of diabetes, increased risk of death increased risk of obesity, and an increased risk of death due to diabetes. And so again, across these different multiple health outcomes, we see this disparity. And the reality is these disparities aren't new, that we've seen these disparities existing for decades and across generations, but we haven't been able to really tackle these disparities. And so we have to start to think in new ways than we've thought in the generations before us. So if we look at COVID, so we have all these disparities that exist within these chronic diseases and these life expectancy outcomes. When we look at COVID rates, and this is COVID statistics by race for the state of Ohio, what we should expect to see if there's no disparity in COVID is that population column, where we see 14% of Blacks, we should see 14% represented in all those other categories if we don't see a disparity. But what we are seeing is, while we're not seeing disparity in terms of cases among Black populations currently, we are seeing a disparity in terms of the population who's being hospitalized due to COVID. And then in relation to that, we're also seeing a disparity in the death toll. What's interesting about this slide is I updated this slide from a talk that I gave back in maybe November. And so I did have to, or I noticed that there's a decrease in terms of the percent of Blacks that are represented in the number of cases. But what's interesting about that is that we're also seeing an increase in the number of cases with this unknown race category. So in the very beginning of the pandemic, we were not doing a good job nationally at capturing race and ethnicity data. But over time, we were doing a lot better, where we were getting about 90+% of folks who tested positive, we had data on their race and ethnicity. But it seems like over the last few months, we're kind of not doing as well as we had been doing in terms of collecting that data. So while we're not necessarily seeing here in these numbers a disparity among Blacks in terms of the number or percent of cases that they represent, we don't know who that 22% of unknown cases are, and they might be the racial and ethnic minorities. Because again, I'm seeing that I had to decrease the percent of cases in the Black population, but also there was this increase in this unknown. And that's the same here for Hispanic populations as well, where we have 36% of cases with unknown category for ethnicity. And so we're not really sure if we are seeing a disparity or not, because we're not doing a good job at capturing that data across the state. And so if we look at why do we see these racial and ethnic disparities in COVID-19, here's what the CDC has said. They said that it is the longstanding systemic health and social inequities that have put some members of racial and ethnic minority groups at an increased risk of getting COVID and experiencing severe illness regardless of age. So at the national level, we've had this recognition that it is not individual behavior. So here in the state of Ohio, some months ago, the director of the Ohio Commission on Minority Health was presenting to the State House around racism as a public health crisis. I refuse to remember that legislator's name, who basically questioned Director Dawson about, is it that we're seeing this disparity because we see Black and other minorities not washing their hands or not social distancing, right? So we're putting the blame on the individual. But here, the CDC is telling us that it's not individual behavior that's the problem and why we're seeing these disparities. It is our systems. It is the inequality within our society. That's why we see these disparities. And so that's what the CDC said in 2020. Here's what Martin Luther King said, as Fabrice already mentioned, in 1966, that of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And so I've heard this quote many times over the years as a kind of a way to say that, like, here we are decades later, and this this quote still has so much relevance to what we're seeing. But I never really took the time to figure out what context was he saying this in, right? Not that I question the validity of what the statement means, but we all know that context matters. So I really wanted to understand, what did Dr. King say before and after he made this statement, and where was he making it? So I did a little research in preparation for this conversation. And it looks like this was made at a press conference in preparation for a speech that he was giving to a medical association in Chicago. And so here's kind of what he said before. So right before he made that statement, he actually says that we are concerned about the constant use of federal funds to support this most notorious expression of segregation. And the segregation he's talking about here is the segregation of Black and white patients within hospital systems. And then he goes on to say, of all forms of inequality, injustice in health is the most shocking and the most inhuman, because it is often results in physical death. I want to point out here that actually it has been misquoted over and time again, apparently, and I just found this out, as well as healthcare, but really he's talking about health. But we have to remember that this is 1966, and oftentimes when we thought about health, we were talking about healthcare. But I wanted to take this back to his original use of the term health and not healthcare, because I think it's really important that when we think about the injustice that we see in our health inequities, we have to think about health holistically beyond what happens in our traditional healthcare setting, which leads us to talk about these social determinants of health. So these social determinants are defined as the conditions in which people are born, grow, work, live, age, and the wider set of forces and systems that shape the conditions of daily life. And when we think about why this is important, in the context of why we need to talk about social determinants of health, we can start at the top of this graphic at the right with those green boxes, so health outcomes, right? So in the context of Dr. King's words, this is the inequity in health that we see. So we can think about health in terms of the length of life that someone experiences, or the quality of life. And if we think about what goes into those health outcomes, then we end up with these blue boxes. And so oftentimes in health, we're so focused on those first two. So we're looking at health behaviors, right? So in the context of COVID-19, this might be, we're asking people if they're social distancing, are they wearing their mask, are they washing their hands? But we know from science, not necessarily just around COVID, but even around diabetes, for example, and looking at diet and exercise, we know that health behaviors only contribute 30% of what makes up a population's health outcomes. The other 20% comes from clinical care, so that traditional healthcare setting. So, and again, an example of COVID-19 is thinking about, do we have access to testing in communities? But we know that's only going to contribute to an additional 20% of those health outcomes. So we got to talk about our social determinants of health, which is the other 50% of that pie. So that's those social and economic factors in that physical environment. Again, an example of COVID-19 is, what type of employment does a person have right now? So not only are you employed, but what's your type of employment? So I work at Ohio State, and I've been privileged enough to work from home since last March. My mother works in retail. She's had to go to work every day and constantly interact, despite the fact that she has multiple health outcomes that will put her at a great risk of having some really bad outcomes if she were to get COVID, right? But her job doesn't necessarily allow her to work from home. It's not that type of position. So we got to think about the context of what, those social and economic factors and how that contributes to health outcomes. And we also have to think about physical environment. So do you live in a very high, dense, populous part of town, right? And if you do, that's going to also put you more at risk of something like COVID-19. But even in terms of like non-COVID terms, thinking about the physical environment, the air quality in which you live, that might contribute to a higher population or a higher risk of asthma within a population. And if we think about, all of these different health factors and what contributes to them, then we end up with our policies and our programs. And we have to start to think about how our policies and our programs can impact these health factors that are ultimately going to impact our health outcomes that we aim to improve. So next I want to walk through a few examples of the distribution of social determinants of health. So one of the things that Kirwan is known for is our map making abilities, and really depicting and telling these stories through maps. And so I want to talk about social determinants in Montgomery County using several maps. So this first one is education. So it's looking at the percent of population with less than a high school education. So as the color gradients get darker on this map, that's where we start to see a higher percentage of the population with less than a high school education. What I want you to focus on as we walk through these maps really briefly is just the pattern of where we're going to see these disparities clustering, right? So as we get to the Dayton and surrounding Dayton areas, where we're going to see this higher population with lower education. When we look at something like poverty, similar map. As poverty is increasing, you're seeing darker gradients of colors. And again, it's in those same pocket around the Dayton areas where we're going to see these higher levels of poverty within communities. When we look at something like the percent of population with health insurance, or this should be without health insurance, what we see, thanks to the ACA, we don't see a lot of, we don't see a lot of those dark orange colors in this map because a lot of folks are able to get health care through the ACA, but we are seeing certain pockets, again, in those same regions where we see, more poverty, where we're going to see less people with health insurance. And then the final map, I believe it's the final map I want to show, is this is transportation. And oftentimes when we think about social determinants of health, transportation is one that people don't sometimes always think about. I think this is really important in the context of COVID-19. So this is a map. As the colors get darker, again, it's a higher percent of the population that don't have access to a vehicle. Now think about, and it's been almost a year that we've been in this pandemic, but think about, what life was like for all of us last March and April, right? So we're in lockdown. We don't really know what's going on, but we know we want to stay distanced from people as much as possible to stay safe. Now, what happens if I live in a household without access to a vehicle? And perhaps maybe I'm a low-wage worker, so I need to get to work, but I rely on public transit. And what did a lot of large cities do back in March or April of last year? Well, they reduced public transit in order to reduce movement for people as a response to the pandemic. And not to say that they were wrong for doing that, but the repercussion is you also now cut off a population from getting access to resources that oftentimes don't exist within their community within walking distance. So now you've created a system where our most vulnerable population are now isolated from getting access to the services and things that they need, or to just to get to work every day. And so we can look at all of these indicators individually, or we can look at them collectively, which is what this Childhood Opportunity Index 2.0 does. So this is a collaboration with Brandeis University and a colleague at the Kirwan Institute that looks and takes measures across education, some health and environment indicators, and socioeconomic indicators, and creates this index of opportunity. And then they kind of break them off into these categories of neighborhood level opportunity, ranging from the lightest color, which is the very low opportunity, to the darkest colors, which is very high opportunity. So this is a map that shows the Dayton metro area, so larger than just Montgomery County. But what we see is, again, that same cluster around Dayton areas where we see the lowest levels of opportunity occurring. And so again, just noticing this pattern that across all of these different indicators, it's those same areas where we're seeing disparity and the lack of resources. And if we look at who's impacted, so who's living in that core area, on the map is the left of the population, the white population. And as the colors gets darker, that's where we see more white population, in contrast to the map on the right, which is the Black population. Again, as we get darker colors, more Black population. So you'll see that in the areas where we saw the most disparity is where we also see our highest rates of Black populations in comparison to white populations. Another way we can look at this is, again, using that Childhood Opportunity Index that looks at neighborhood opportunity level across these categories. When we look at the Dayton metropolitan area, when we look at the very low opportunity neighborhoods, we see that 20%, I'm sorry, not 20, I want to go to the green, 8% of white children in Dayton are living in these very low opportunity neighborhoods, compared to 65% of Black children and 28% of Hispanic children, right? So more than half of Dayton's Black children are living in these very low opportunity areas in the Dayton metro area. So not just the city, but the metro area. This is in comparison to if you go all the way to the right in that very high. So what children have the privilege of living in very high opportunity neighborhoods? Well, 25% of white children live in these very high neighborhoods, 16% of Hispanic children, and only 4% of Black children in the Dayton metro area have the privilege of living in these very high opportunity levels. And so this is comparable to what we see across the largest 100 metropolitan neighborhoods, according to this analysis, where we see 46% of Black children living in very low opportunity neighborhoods, compared to 7% of Black children that get to live in these very high opportunity neighborhoods. So I say to say that what we see in Dayton is not unique, but across the board, across this country, we have our children starting off at a disadvantage because they're living in these very low opportunity areas in comparison to those very high opportunity areas. So if we start to have a conversation of where do these disparities originate in these social determinants of health? So now getting back to that history. So we talked about social determinants of health and what they are. So they can fall into these different buckets. So we have safe and affordable housing, quality of education, availability of food, and so on and so on. When we think about how do these social determinants of health impact health, we kind of talked about them already, but it's this, the thought is that how you experience these things, your level of access to these things can cause differential experiences of psychological stress or engagement in unhealthy behaviors. And then that's what leads to these, the disparity in the distribution of disease, illness, and wellness. But if we take a step back and say, well, where do these social determinants of health come from? How do we get this, this inequitable distribution? Well, we can talk about the power and wealth imbalances that exist in our society. And we see that played out through our housing policies, our education systems, our social safety nets, and so on and so on. But if we take a bigger step back and say, okay, well, where do these power and wealth imbalances stem from? Well, then we end up with our root causes, which are institutionalized racism, class oppression, and gender discrimination and exploitation. And we can have the rest of this time talking about any of these three buckets based on my expertise in the work that we do at Kirwan. I'm going to focus on institutional racism. So I want to start off by kind of setting the ground of like, what do I mean when I say racism? So racism is defined as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, i.e. their race. And it does these three things. One, it unfairly disadvantages some individuals and communities, which is oftentimes what we think about when we think about racism. But it's important to note that it also unfairly advantages another individual and community. And then it saps the strength of the whole society through this waste of human resources. And when, that last point is really hitting on the fact that if we all had the exact same opportunities, the exact same access to resources, right? How much better could our society be? Because there's genius in these very low opportunity areas that we don't get to flourish in our children because they just don't have access to the same resources. And so as a society, the idea is that as a society, we would do better as a whole if everyone had, a just opportunity to all of these resources. And when we think about racism, we think about the way it operationalizes, and typically we fall into these three buckets. And oftentimes when people think about racism, we're thinking about that bucket all the way to the right. So we're thinking about that personal mediated racism, right? So when we think about racism, our mind might go to like KKK, that's personally mediated racism, what's happening between two individuals. But there's also this internalized racism, which is me as a Black woman, what do I internalize it means to be Black? What kind of inferiority kind of complexes might I exhibit based on all of the information that I'm being fed in society? But really what the most pervasive that we see is this institutionalized racism, which is this, what's embedded within our social norms and within our policies that can operationalize without the existence of a racist individual, right? It's like, so we didn't need 45 in presidency to have institutionalized racism throughout our society, right? It's been a historical insult, and that's transcended throughout generations. And it's really important to note that we can't understand our present without first understanding our past. So this is a graphic that looks at, what has, and this is as of 2019, that 400-year anniversary of the first African slave, being brought to the U.S. Kind of what has that 400 years look like for African Americans here in this country? And so the recognition here is that we had 246 years in slavery. There was 99 years in segregation, and there's 55 years of this kind of freedom that we supposedly have. And it's important to know that free period that we have is only 14% of our experience here in this country. And it's really important to point out, because I think sometimes we think about this history as being, 400 years does sound like a long time, but I'm always reminded that, my mother was actually born in 1965. So it's not that long ago. We're not talking about something that happened, generations and generations ago. We're only really one generation. I'm only one generation removed from the Civil Rights Act. And so it's really important to understand that we're not that far removed. And I think that, especially now, I think we can all see how far removed we're not, right? Because hopefully we all saw what happened last week at the Capitol. which shows us that we're not necessarily so far removed from this history and this hatred in this country. So in order to make sustainable changes, we have to also look at these historical policies, because the reality is our historical policies have shaped our present day communities, and we haven't done the work that we needed to do to right that wrong. And so I'm going to briefly talk about 3 policies that have shaped our communities. So that's zoning, the construction of highways, and redlining. So first, I'm going to briefly go over zoning. So zoning had a purpose. So it's the way in which we zone the use of land for industrial, commercial, public use, or residential use. And it had a purpose that was rooted in public health. So the idea was that I can buy a piece of land today and build a house for me and my family, and that the next person couldn't come the next day, buy the land next to me to build a factory, right? Because they would have public health implications on me and my family for breathing in the fumes of that factory. But also we live in a capitalist society. So zoning also had a purpose in terms of preserving property value, because my property would be less valuable if it was next to a factory. But what we've seen is that the zoning policy has been used in more insidious ways. What we've seen, for example, in Baltimore, I believe was the first city that had racialized zoning, where they zoned neighborhoods based on race and ethnicity. In less explicit ways, we've also used zoning to racially segregate communities. One way is to set zoning policies that state minimum lot sizes or set building material standards. So for example, if I want to create this new community in this undeveloped area, I'm going to zone this area so that each parcel of land that gets sold can't be less than a half an acre or maybe even a full acre, right? So in doing that, I'm now really segregating by socioeconomic status, because you have to be able to afford a piece of land that's half an acre large. And unfortunately, in this country, we know that economic and race is often tied together. So that was also a way that you could also exclude people from race as well. And then the next policy I'm going to talk about is redlining. So many of you probably heard about this one. So this was a process that was used to assess neighborhood risk to determine eligibility to receive these federal loan insurance. So to set the stage a little bit about what was happening at this time. So this is a policy that happened between the 1930s and then in the 1950s. And again, this is done by the federal government. What's happening at the time is the way that we paid mortgages the way that mortgages were paid looked a lot different than what they look like now. At that time, prior to this HOCA association, mortgages were paid so that you took out a mortgage and you made monthly payments, but your monthly payments were really only paying the interest on your mortgage. And at the end of your mortgage term, you were expected to pay the lump sum. Sounds absurd. It was absurd. A lot of folks started to default on their mortgages and the banks were crashing. So the federal government stepped in and said, okay, we can't have all our banks across the country crashing. This mortgage system doesn't make sense. So we're going to come up with this federal loan insurance so that we can back those mortgages, so that if a person defaults, the federal government can step in so the bank doesn't crash. But we have to figure out, how do we assess risk? So where now we might use something like a credit score, the federal government decided that we were actually going to assess risk at the neighborhood level rather than the individual level. What's important to know that this established our modern day mortgage, and banks use this practice in every city throughout the US. And so what these HOCA assessors came in and did, where they were assessing neighborhood risk, oftentimes it was based on race and ethnicity, and they were grading neighborhoods A, B, C, or D. If you're an A-graded neighborhood, you received 80% of your mortgage backed by the federal government, which is why we traditionally, even today, we see that if you want to buy a home, they say you should have a 20% down payment. That's based on this practice. And then the percent that you receive backed decreased as you kind of went down this grading system. And if you were a degraded neighborhood or a red line neighborhood, you receive 0% of your mortgage back, which pretty much left you unable to receive a mortgage, or you had to now go to some sort of predatory loan practices in order to receive a mortgage. What's important to note about this is that in this country, we build wealth through land and home ownership. So this practice that happened over decades prevented generations from home ownership, which then has an impact on generational wealth, right? Because that left families unable to pass down homes, from grandchildren to grandchildren, that we see happening in a lot of white communities. And so I'm going to come back to talk about a little bit more about redlining, but want to talk about highways because oftentimes these two things work in tangent. As we saw kind of white flight in suburbs kind of popping up in the 1950s, we now needed to make these highways and these urban renewal projects in order to create this highway system that would allow people to live in the suburbs, but still work in the city and kind of have easy access to get back into the city. But we know that these projects primarily impacted our low income and minority communities, and we saw massive displacement. So in Atlanta, an example, 1 in 9 people were displaced across the city. We know that this had financial and psychological impacts on the population that were being relocated. What we know for low income individuals is that one of their biggest resources is one another, right? So that community that we build. And so in relocating people, you are separating them from their resources, which is having a lot of, again, both financial and psychological impacts on individuals. Minority people or people of color were oftentimes relocated to overcrowded areas and new areas of high density public housing. Now flash forward to 2020 and the COVID pandemic. Again, we've set up a system in our society where we have these overcrowded neighborhoods, mix that in with the COVID-19 pandemic. And of course, we're now gonna have outbreaks happening in these communities that we have designed to be overpopulated. And then we saw that more houses were destroyed than were ever rebuilt, where 90% of the homes that were destroyed in this process were not being rebuilt. And what's important to note, and so this is a map of Dayton and looking at the redlining map. And then my little illustration in red are where the highways cut through in Dayton. And so what you're gonna pay attention to notice is like these highways are primarily cutting through only the red line areas, right? So the highways perfectly were constructed so they did not interrupt those blue and green areas, so those A and B graded areas where white individuals were living at the time, but it cut through the Black areas as well. And so that's not unique to just what happened in Dayton. We see that happening across the country. So this is one of my colleagues has been doing some work kind of trying to see like how many of these highways that were being built were cutting through those red line communities. And at the national level, we see 47% of highways that went through these HOC assessed areas were cutting through degraded neighborhoods compared to only 3% of the highways actually touched or like displaced people in those A-graded neighborhoods. And if you look at Ohio, a little less in terms of like in totality in the degraded neighborhoods, most in Ohio were cutting through those C-graded neighborhoods, which still were low income minorities and also a lot of immigrant white populations, low immigrant white populations at the time as well. And so again, we're displacing our low income and minority communities and we're not displacing our white and wealthy populations when we're building highways. All right, so that is our history, and now we're 70 plus years later, and so why does this history even matter? Like, why do we have to have this conversation about redlining and zoning and highway construction? Well, it's because we've built a system of segregation that persists today. So if we look at Dayton, and this is looking at the historically HOC assessed neighborhoods, kind of what was the population as of 2016 in these neighborhoods. So in Dayton, in those areas that were historically A-graded, in 2016, 86% of individuals living in those areas were white, and 80% of those individuals living in those areas are, that MUI stands for middle to upper income. In those historically degraded neighborhoods, 57% of them are present day minority, and 82% of them are low to moderate income, right? So we've now, historically, we made a policy that segregated our community, and we haven't fixed that segregation that we created. And I don't have I don't have here to show the national rates of those numbers that I'm showing here, but I can tell you that at the national level, it's the same in all the major cities across Ohio as well. It's the same in terms of we have created this system of segregation and it persists. So now I want to talk about how does this impact health equity. So one, start off with this graphic, really explaining the difference between equality and equity, because oftentimes we hear these two words used interchangeably, but they don't mean the same thing. So if we start at the graphic at the top left-hand corner, it's this inequality, right? So we see this tree. There is something structurally wrong with this tree. this tree is bent and it is leaning to the left. And if you look at the children at the bottom, the person on the left hand side of the tree, you know, apples or opportunities are falling in their lap. But the kid on the right really can't get access to those resources. And if you look at the tree itself, you'll also see that there's a lot of apples growing on the tree to the left-hand side, but not very few on the right-hand side. So if we now shift over to the right and look at what does it mean to have equality? Well, equality says we're going to give an even distribution of resources and assistance to people. So this means that we're going to give both of these children a 6-foot ladder. Well, that helped the kid on the left, because the kid on the left now has access, can easily grab at the opportunities that that tree has to offer. But the kid on the right is still struggling. There's still not enough to get them to reach the tree. So then we can have a conversation about equity. And equity is we're going to give you custom tools to help you get the access that you need. So yeah, the kid on the left, a 6-foot ladder is good enough, but maybe the kid on the right needs an 8-foot ladder. And so now he can reach the tree. And that seems good. But if you look at the tree, there's still something structurally wrong with the tree. And the tree is still producing more apples on the left side than it is on the right. So finally, we have to really move our conversation past equity, start talking about justice. Now we have to fix what's wrong. We have to fix the system, the structural problem with the tree. And when we do that, now we see apples growing evenly across the tree. And now those children both can reach the tree with a 6-foot ladder. So now we can talk about, now that we have justice, we can talk about equity, or I'm sorry, equality, in terms of them both having a 6-foot ladder, but only when we fix the structural problem that exists. So now I want to talk about the inequities, going back to the beginning, kind of talking about inequities that are happening. Inequities that are happening in terms of like the allocation of resources, right? So this is looking at COVID-19 vulnerability or vulnerable populations in Montgomery County by census tract. So this is some work that was done in collaboration with Deloitte and the Department of Health, really led by Chip Allen at the Ohio Department of Health, looking at trying to help local health departments identify where are our vulnerable populations in this pandemic. And what we did here was we used these indicators of comorbid conditions and where we saw a low income populations to identify where in the county do we see vulnerable populations. So as the color grading gets darker, that's where we see vulnerable populations to COVID-19. And then you'll notice again, those same areas that we saw in all the previous maps shown today are the areas where we see our most vulnerable population to COVID-19. So we have vulnerable populations to COVID-19, but this is just showing that these populations are vulnerable to a lot of different health outcomes, right? So this is looking at lead poisoning in children. And this comes from, again, that community health assessment for 2019 that came out from the Dayton and Montgomery County Public Health Department. So this is showing again that we have the same concentration of lead poisoning happening in those same areas. So it's not only are you vulnerable to COVID, these are populations that are vulnerable to lead poisoning. When we look at, again, the resources that these communities have, this is food deserts. So those areas are also the areas that are highlighted in red are the areas where we see food deserts. So those vulnerable populations also have food deserts. Thinking back to the map I showed of transportation, it's not shocking that these areas where we see food deserts are also the areas where we see a higher percent of the population without access to transportation, right? So now, not only do they not have the resources in their community, they also lack the resources to leave their community as easily to get the resources that they need. And then finally, I want to show this map of what kind of resources are we pouring into these communities, right? So they're not getting access to healthy foods through having grocery stores, but what kind of resources do exist in these communities? And this is looking at the density of alcohol, retail, and tobacco vendors in Montgomery County. And as the colors get darker and redder, that's where we see a higher density of these different retailers. So on the right, you see alcohol, on the left, you see tobacco. So these same areas that lack grocery stores are the areas where we see the most alcohol and tobacco retailers. And again, going back to the difference between individual behavior and environment, it's important to know that these retailers aren't in these communities just because the people living in those communities are more likely to drink or more likely to smoke, right? There was a marketing strategy to put these retailers in those areas. I can guarantee you that the areas where you don't see alcohol and retail vendors probably had residents who have been, I want to say trained, but have learned through generations that their voice matters, that they have control over what happens in their community. And they probably advocated to not have these retailers in those communities, whereas the communities that are saturated with these retailers are the folks that we have shown through our actions that we haven't listened to them. So we haven't empowered them in the same way to feel like they have action that can be taken in order to reduce these retailers in their community and actually bring in the retailers that are going to help them live healthier. So I want to go back to this quote from MLK, really pointing out that this segregation that he talks about, while he was talking about the segregation in specifically within the medical setting, wanted to point out that this segregation also happens at the community level. We see that segregation happening with our resources outside of a hospital. And we know that this segregation is resulting in physical death within these communities. And we see that through our life expectancy. So I don't have a map for Montgomery County in terms of life expectancy, but I know here in Franklin County, Kirwan did a study some years ago looking at life expectancy by census tract. And we know that areas that are pretty much adjacent to each other have a 5+ year age gap. And it is because that lack of resources, that segregation that we've created within our communities. So how do we achieve equity? So here's the last time I promise that you're going to see this quote today. So wanting to also talk about what did he say after that? So he made the statement that it's the most shocking and inhuman because it often results in physical death. But he went on to say, and I see no alternative to direct action and creative nonviolence to raise the conscience of the nation. I think that's where we are today. That we have to figure out what is that direct action, that creative nonviolence that we can do in order to not only just educate people about what's happening, but also create change within our communities. So what can we do? Hopefully this has been like the thing that I've hit on all day, is that we have to start thinking beyond the individuals, right? This is not a problem with the people. It is the problem with the systems and the environments that we have created, that people can only make choices based on the choices that they have. And so we have to look at the environment that they live in and address those things that's preventing them from making the choices and living the healthiest life that they can actually live. Then we have to make an assessment of what are our present day inequalities within the areas in which we live. And we have to figure out kind of what are the gaps, like what do people need? And then what are the drivers behind the things that are, that are causing these inequities that happen within our communities. And then finally, we have to understand our histories, because again, if we don't pay attention to what happened in the past, we'll just end up repeating it or never really addressing it, and therefore never get into the root cause of the problem. And then we have to call attention to these past injustices and then work to address them. We need to address the social determinants of health, because again, that's that 50% of what contributes to health outcomes within our communities. And so 2 things to note that we can do here is this initiative called Health and Equity in All Policies, which means if you don't work in the health sector, if you work in education, transportation, housing, whatever it might be, recognizing how is health related and connected to those things, because I can connect health to anything. And then what is the equity? What equity is happening? Are you creating policies that have a lens towards equity? Remember that picture, it's not giving everyone the same thing. It's recognizing what do people need? And is this policy giving those who are most disadvantaged the thing that they need? And then as we're having these COVID relief dollars happening, I know Congress hopefully is gonna have another COVID relief bill, thinking about where and how those dollars are being allocated and used. If your organization that you work with have any sort of dollars, how are you using those dollars to address these inequities within communities? And then finally, there's this need to collaborate across agencies and community members to address those gaps and the causes, thinking about both present and past policies. And we have to do it at this multi-level approach, right? So we have to come together. This problem, this health inequity that happens, it's happened and it's been building for generations. It hopefully won't take us generations to fix it, but we have to come together collectively to target all of these problems at these different levels that it's occurring. And with that, I would like to thank everyone for coming today and listening, and I will take any questions.
Thank you, Dr. Barnett. I don't know how you were able to fit in all that insight. And so, yeah, grab that water for sure. That is a lot of information, but a lot of necessary information to understand the scope of the issue, obviously. At this point, I definitely want to let the audience know that they can start to throw questions in the chat, whether you're viewing from your Zoom registration or on Facebook. We have our community engagement coordinator, Kierra Thomas, who will be sifting through that chat to really pull some of those questions so we can ask Dr. Barnett. But while folks are submitting their questions, I have a couple questions. I'm going to be a little bit selfish. I just have a couple questions for you, Dr. Barnett. Oftentimes when we as a nation try to have this kind of hard conversation, it's sometimes reeled back in with the proverbial comment that things have gotten better, or we're in a better place than when we were when Dr. King made this statement. So I want to ask you, where do you stand on that assessment?
Where I stand is, I think that if last week didn't show people how far we have not come, that I'm not sure, one, what else will, right? So at that point, you're just in denial. But I think that for folks to say that, one of the things I like to show people is like, I'm not going to tell you about how I feel. I'm going to show you the numbers, right? We're going to talk facts, because you can dismiss my feelings and my opinions all you want, but you can't dismiss the numbers and the facts. So the reality is, especially when we talk about health inequities, we haven't gotten better, right? We still have Black babies dying at 4 times the rate as white babies, right? In Montgomery County, but also, we see that disparity across the state and across the nation. So we haven't gotten better. And I think we see that disparity happening not only in health outcomes, we see the economic disparities that haven't gotten better. We see the education disparities that haven't gotten better. And again, it's not because of individuals, it is because of the system. So that's how I would challenge the folks that say that is, I need you to look at the numbers and show me, because the reality, we think it got better because for a time before 45, right? There was a time where, it wasn't PC anymore. It wasn't politically correct to say some of the things and do some of the things that people deem as racist. And I also have to remind people that racism is not just about the interaction between two people. It is about the system. And if we haven't corrected the system, then we haven't come far.
Thank you for that perspective, because I do feel the same way, as long as there are still preventable deaths happening within these minoritized communities, and yes, we haven't gotten far enough, essentially. So I want to move forward and ask, just in terms of what we're observing today with the coronavirus, can you shed some light on the perspective that some may have that this all started with COVID, and referring to the disparities and the health inequities that apparently weren't around before March?
Yeah, I think so. COVID has been, I don't want to call it a blessing and a curse, but in a sense, it has opened the eyes to people about the disparities that exist, right? So there are people who didn't even know what the CDC was, right? Didn't understand that, there's this lack of I won't say education, but education and knowledge around these health inequities for people who don't work in public health, and even for some people who work in public health, right? Because you get so focused in the silo of the work that you do, you don't see the bigger picture sometimes. So one thing that COVID has allowed, I think, is to shed light on these disparities that are happening. Sorry, I'm trying to temper what I'm saying, but they have shed the light on these disparities. And again, not even just about health disparities, but we've seen, a lot of conversation around the economic impact of COVID-19. For the sake of time, I didn't show these slides today, but a lot of data around, who was losing their job during, in the early stages of this pandemic. It was our racial and ethnic minorities more so that were losing their job, more so than their white counterparts. And so we see this disparity being highlighted through COVID. My only hope is that moving forward, we continue this push, we continue these conversations. And like I said, just beyond COVID-19, because we've had these disparities existing for generations before.
Absolutely. And I asked that question because right now, many health-based organizations are dealing with this vaccine hesitancy in this fight against COVID, right? And I wanted to show that this mistrust and doubt did not come out of thin air. And there are members of our nation and our communities around the country that have continuously been let down by our system. Look no further than the Tuskegee syphilis study, the Flint, Michigan water crisis, the mental health toll of the separation of families at the border, and even the touted father of modern gynecology, J. Marion Sims, performing experiments on Black female slaves. It would take a lot of time than we have today to talk about these occurrences of injustice in detail, but I certainly want to encourage viewers to embark on that research if you have not already. So with that said, from your perspective,
Dr. Barnett, really quickly, if I can, that even, for folks who are working in public health, those things are important to acknowledge, because, if we want to push past that, if we try to push past that history and jump to, but you should trust the science, trust the vaccine, which is that slogan that I've seen multiple times, trust the science, trust the vaccine. Valid thing, right? We should trust the science and the vaccine. But if we do that, if we push that onto communities without acknowledging the real history that happened, right? How can they be confident that this isn't one of the same? We have to be willing to say, we messed up, right? And Tuskegee was a federal, it was a federally funded, experiment. So we have to acknowledge that we've messed up in the past. Here's how we want to do better. And we have to be willing to come in and say, yes, we want you to get vaccinated. We recognize you have these other issues. We want to actually work with you to address those issues too. So we can't walk into communities pushing the vaccine, ignoring everything else they have going on that they need help to address. We have to do both.
Right, and you're a step ahead of me, because I was going to ask, just from your perspective, how should local health organizations approach their minoritized and disadvantaged community members? And these are the same community members that are the most vulnerable to the impact of the COVID-19 crisis. So how should they approach them to foster that trust and to foster that confidence needed to achieve this community immunity that is so important to beating the coronavirus? So you already touched on it, but is there anything else you want to speak on with that topic?
Yeah, I think, similar to what I just said, is that we have to go into communities and talk to community members about what is it that they need beyond this moment. What do you need? And then we have to be willing to do the work in the long haul to show them that we're willing to do those things in any way that we can, right? We don't have the magic wand. We know funding is always going to be an issue, but we have to show some good level of faith that we're willing to do the work that it's going to take.
Absolutely. So I'm just going to jump into some of the chat submissions that have been sent my way. So first question is, will this presentation be available online? And yes, it will be. This is being recorded. And as soon as this event is over, I know our public information team will be working to make sure that this video file, and this recording will be provided to the public, for anyone who just didn't get the chance to view it, or if you wanted to share with a contact. Another comment and question is a fantastic presentation, of course, and the question is, on the public policy front, are there specific funding priorities that you're supporting or watching during the Ohio State budget negotiations this spring that affect health equity and justice? So I can repeat that if you need me to.
Okay, I got it. One of the things that I think we should all probably pay attention to is what's going to happen around housing. We know that housing is a major determinant of public health or health outcomes. So having stable housing. I know here in Columbus, for example, the housing courts were shut down, again, thinking back to March and April of last year. But when they reopened, they actually didn't have it in the federal courthouse or the I guess county courthouse, not federal courthouse, but they didn't have it at the courthouse. They actually opened up the convention center to have it. One, because it helped spread people out, but two, because there were so many eviction filings that were occurring. And so that's going to be something that eviction is a problem that it's been a major public health crisis that we haven't talked about for a long time. But with COVID, with a lot of people losing their jobs, it's going to get even worse. And so paying attention to what are we doing to secure housing for individuals, because we also know that affordable housing is hard to come by. I do a lot of work with the Ohio Commission on Minority Health, and particularly around their programming around pregnant at-risk moms. And housing is an issue in the 4 years that I've been working with that organization that keeps coming up for their moms throughout the state. And so really paying attention to what are we doing with our next budget around affordable housing.
Gotcha. And jumping on to another question I see here. So As health systems, we all have to do a community health needs assessment and develop a health plan which results in a lot of activity. Do you think that we focus too much on interventions and activity and not enough on advocacy?
I think we have to do both, right? Because there's this need to do, I'm going to call it short term, but it's not short term, but it's this need to do these immediate programming, these immediate activities that are going to impact people today. So we have to do that, but we also have to do the policy advocacy and the policy work as well. Again, going back to the example of the work that I've been doing with Angela Dawson in the commission, our role at Kirwan is to do that policy advocacy, that policy work, but the commission is also doing their programming. So figuring out how can you do both, right? There's room to do, you don't have to choose one or the other. You really should be doing both. Again, attacking the issue at those multiple levels.
Right. And just somebody commenting on the amazing research you've done. So in your research, Dr. Barnett, have you come across communities that are successfully addressing equity and social determinants of health that could serve as a model for us or any other communities looking to improve and do better?
I need to work on answering that question. Like always, like my brain always goes like, what are people doing? Because I think people are doing great work. Again, not to sound like, this repetitive person, but I do think the work that the commission is doing is great. We are seeing in the moms that go through their program they are seeing better health outcomes. And Dayton actually just opened up a hub this year in January 2020 with the commission as well. So I think that would be one example. So just a brief background of what that program actually does. So they actually work with community health workers, and they're getting pregnant moms access to all of these different resources. Talk about social determinants of health. If a mom has a need for education, employment, food, housing, they're trying to connect them with the different social services to get them the things that they need. And again, so they're doing the programming, and then our role as Kirwan is to come in and to look at what they're doing and then identify policies that's like, this policy keeps coming up as a barrier. Here's what we need to address within that policy to remove that barrier. So I think that's a really good example. And we're seeing really good outcomes for the moms that are within that program.
Gotcha, right. And I really look forward to there being a day where we can name the positives and the positive examples and the models as quickly as we can, the negatives, and right, the X marks essentially. So fingers are crossed for that, absolutely. So it's a little less hard to answer that question in the future, hopefully. So moving forward, I want to just kind of point the community to, and I don't know if you're done with your PowerPoint, Dr. Barnett, is that most of it? Okay, yeah, I just want to point before we end out, I want to point the community towards this vaccine attitude survey that we have implemented locally in the county. And in essence, the survey provides our community members with an opportunity to voice their concerns and worries about the vaccine directly to the health department. As we move forward with our vaccination efforts, the results of the survey will guide our actions and help make sure we have every single community member in mind. We want to know why you're hesitant about COVID-19 vaccination, what we can do to change that, and what we can do to make vaccination as convenient and as accessible as possible to everyone. It's a brief survey, about 5 to 10 minutes to complete, that can be found on our website, phdmc.org, and our social media page, for example, our Facebook, for those who are viewing through Facebook Live. We've also been working with numerous community groups to have it shared to every corner and neighborhood within the county. So we are keeping the survey open indefinitely because we will likely be engaged in vaccination work throughout the year. So for those who haven't yet participated, you can still let your voice be heard. And you can either kind of scan the QR code on your screen right now, or visit our visit phdmc.org, or check out our Facebook page. But once again, it's 12:58, and I know this is a lunch and learn, so it's supposed to end at lunch, right? And hopefully nobody has not had the chance to have lunch right now. But I want to thank you again, Dr. Barnett, for bringing your expertise to the table, and for really breaking down some very complex and nuanced concepts. I want to also thank Dawson Powell, who is with our public information team, who is handling the tech in the background and making sure things went smoothly. And I'm hoping that at least from the viewer end, it looked as smooth as I'm seeing at least. And I also want to thank Community Engagement Coordinator Kierra Thomas for navigating the chat and making sure that some of those questions got answered as well. And Dr. Barnett, I don't know if you have any last words or anything else you want to share about what you're working on, but I want to, kind of give you the space to close us out if you'd like.
No, I just want to once again thank you all for inviting me to be a part of this conversation today. You can connect with me on Twitter or LinkedIn, or go to the Kirwan website to connect with me, and I'll be more than happy to further these conversations with folks.
Wonderful. Thank you again. We hope that your Fridays go well. We hope that this lesson learned was informative, and we definitely hope to provide opportunities like this just so we can educate the community. So it's not just public health with all this information, but that there are other community members, the average person knows the concepts behind what we're working on, what we're trying to fight and combat against. So thank you again, Dr. Barnett. Thank you everybody who is viewing. And for those who registered on Zoom, I will be sending a post-event survey just so we can find out how we did and how we can do better in the future to present opportunities like this in more accessible and digestible ways. So thank you again. I hope lunch was fun, and good luck with the rest of your weekend and the long weekend. Bye.